Welcome, everybody. We're going to let everybody come into the room with us. It takes a few minutes usually. I don't know why it takes a few minutes, but it always does.
Do you send out the link in the email ahead of time, or?
Yes. And reminder emails as well.
Sure.
Everybody's here. I usually give people a couple minutes, but I suppose it has been a couple minutes and we can start because people always have lots of questions. So Dr. Chawla, I think I checked, how long can you stay afterwards? As long as it takes?
Okay. Yeah, as long as it takes. Not till midnight, though.
Goodness, no. No, I can't stay up that late anymore. No, we end by 8:30. So, all right, everybody. Good evening and welcome. I'm Rachel Rosen Simpson. I'm the program manager at the Breast Cancer Coalition. I'm so glad you could all join us this evening to learn more about advances in radiation therapy for breast cancer with Dr. Seema Chawla. We are so grateful to the Lisi Rosenthal Memorial Education Fund that supports coalition educational offerings like this one. Before we begin this evening's presentation, I always have a few housekeeping announcements to share. For anyone who would like closed captioning, it's available if you click the little CC button at the bottom of your Zoom screen. If you missed the link in the Zoom reminder emails for Dr. Chawla's slides to follow along with her presentation, I'll drop that link into the chat as soon as I finish my announcements for anyone who would like it. And then after Dr. Chawla's presentation, I will facilitate a question and answer session. So as you have questions, please type your questions into the chat function, and I'll continue to compile them into a list as the presentation unfolds. And I'll share them at the end with Dr. Chawla, and we will answer as many as we can before we have to wrap up by 8:30. And just a disclaimer that Dr. Chawla cannot give any specific medical advice for an individual case who she isn't already seeing. So if you could try to keep your questions broad and inclusive of others, that would be very much appreciated. If you want to watch the presentation again, it's being recorded as all our presentations are, and it will be added to our webinar library as soon as possible. And we've also been uploading them to our YouTube channel, and they are publicly searchable now. I will drop both the link to the webinar library as well as the link to register for our future webinars into the chat once we're done with announcements. And lastly, there will be a survey that pops up. It's only 10 questions, super quick. And we do utilize your anonymous feedback when planning our future program offerings. So please complete the survey if you're willing to and help guide us in the future. All right, announcements over. Tonight's webinar features a very special guest and friend of the Breast Cancer Coalition, Dr. Seema Chawla. Dr. Chawla completed her medical training at the University Colleges of Medical Sciences, graduating in 1990, and went on to complete her second residency and fellowship in radiation oncology at the University of Rochester. For over a decade, she has served as a dedicated radiation oncologist with the Lipson Cancer Center at Rochester Regional Health, where she is known for her compassionate, patient-centered approach. She is currently preparing to certify for the American Board of Lifestyle Medicine in addition. Dr. Chawla has been an esteemed member of the Breast Cancer Coalition's Advisory Council for more than a year and is a true partner in our mission. She regularly refers her patients to the coalition for additional support, recognizing the importance of addressing the emotional, social, and educational needs that accompany a breast cancer diagnosis. Her commitment to holistic integrative care makes her not only a trusted medical professional, but also a passionate advocate for her patients' overall well-being, which is above and beyond the call of duty. We are thrilled to welcome Dr. Chawla tonight and deeply value her continued partnership with the coalition. So now, without further ado, take it away, Dr. Chawla.
Thank you, Rachel. Thank you for the lovely introduction. I couldn't ask for better. So let's see. I just want to make sure that you're able to see my screen.
Looks good.
Okay, thank you. So thank you everyone for tuning in. We are here to discuss a very important topic about radiation therapy in breast cancer. And let's see, not able to advance my slide, Rachel.
Oh no, really? Technical difficulties. Well, this first slide looks very beautiful.
Okay.
Maybe if we stop share and reshare,
Okay.
it'll try again. Thank you everybody for sticking with us through Zoom difficulties. I know that we've all had many of them over the course of the pandemic and beyond, so ugh. But we will do our best.
Okay.
Let's see.
So is that a good start?
Well, we can see the
Oh, there we go. All right. So
Yep.
thank you.
You're
That's
welcome.
good. So what we're going to cover in this talk is about radiation techniques that improve precision and delivery, who are candidates for radiation, strategies to alleviate and manage side effects, and emerging studies or who may be on patients who may be able to omit radiation. So radiation therapy has been the cornerstone of breast cancer treatment, and it's used in practically all stages. The goal of radiation is not only to increase local control and survival, but also these days we are more focused on preservation of quality of life, and we are de-escalating therapy or decreasing the number of treatments in this day and age. And there have been lots of innovations in this direction. So over the years, there have been tremendous improvement in the surgical field, from very radical mastectomies where they remove the entire chest wall to preserving the muscle, which is called modified radical mastectomy, to smaller surgeries known as lumpectomy. And we've learned that if we add radiation to lumpectomy, the outcome in suitably selected patients is the same as mastectomy. So when we choose lumpectomy as part of breast conservation, we start relying very heavily on radiation treatment. So a word about how radiation therapy works is that we use high dose of radiation. The goal is to kill the cancer cells by damaging the DNA. I don't know if you can see my cursor here. Most of the action of radiation therapy is called indirect action, and some of it is direct action that leads to double-stranded DNA breaks. And the good news is that the cancer cells are very susceptible to radiation compared to normal cells. And they die because they have an unhealthy DNA. And fortunately, the normal cells have good DNA, so they recover quickly. So there are different techniques of radiation therapy that I'd like to talk about. We primarily will focus on external beam radiation therapy. And the other type of radiation therapy is called brachytherapy, which is actually internal radiation therapy. It can be interstitial or intracavitary radiation, and there's something called intraoperative radiation. So the techniques that are used in external beam radiation therapy are 3D conformal radiation mainly. So we've moved away from two-dimensional radiation to using CT scans and reconstructing images in 3D, and then doing radiation that is very conformal. Conformal means targeted to where we want to treat, to what is called intensity modulated radiation. VMAT is a form of IMRT, proton beam radiation, and the other techniques of radiation therapy are called stereotactic radiosurgery and stereotactic body radiotherapy. So the advances in breast cancer radiation have been many. Not only have we made improvement in delivery of radiation, but also we're doing better at targeting. In addition, we are looking at more partial breast radiation, or we're changing the amount of radiation to the tissue that we need to treat based on suitably selected people. And we're also doing modification in the dose per treatment, and we are doing shorter fractionation regimens. In addition, we've had a better understanding about tolerance of radiation to normal tissues, and how do we decide who are candidates for radiation? So we rely on national consensus guidelines and our annual meeting that is updated every year, published by the American Radiation Oncologists all over the United States, and different evidence-based approaches. And radiation therapy is basically tailored to and customized to every individual and their unique situation. So we are in this day and age of informed decision making, and the patient is a focus of understanding the whole realm of radiation. And we offer different fractionation regimens and technologies, and they are also involved in decision making. So they're in the curative setting. We can use radiation in the setting of breast conservation or lumpectomy. And the criteria when we use radiation in the setting of breast conservation is a smaller tumor, or a person could have positive nodes. And after surgery, they have what is called closed margins or negative margins. By closed margins, it means that the tumor is found at the edges of the, around the edges of the normal tissue, but the margin or the amount of tissue that is excised from around the tumor is less than a few millimeters that we want. In the setting of mastectomy, radiation therapy is used when the margins are positive or when the cancer cells are found in the edges of normal tissues, or when there are positive nodes, the tumor is bigger, there are multiple tumors or multicentric disease. And sometimes we offer it in a small tumor where there's high-grade disease, closed margin in a young patient where there are sort of multiple risk factors. So every situation is different. In this era, there absolute contraindications to breast conservations have become very few. These are namely pregnancy or persistently positive margins, like the surgeon goes in back 2 to 3 times and is not able to take out the entire tumor, or there are diffuse calcifications or calcium deposits throughout the breast found on imaging, or in the setting of inflammatory breast cancer, which is a very rare and aggressive form of breast cancer. So radiation is also used after neoadjuvant therapy. Neoadjuvant therapy means where all the treatment is completed. The systemic therapy, I should say, is completed prior to doing surgery, or hormonal therapy or chemotherapy is delivered prior to surgery. And then after surgery, we are asked to do radiation therapy. And it can be done for alleviation of symptoms, and it's called palliative radiation therapy, where we are trying to alleviate ulceration or bleeding from a fungating mass, pain from a primary tumor site, or pain at other sites where the cancer has spread. A newer application of radiation therapy is treating what is called oligometastatic disease or oligoprogressive disease, and I'll touch upon it later. And radiation in preoperative setting is still being considered investigational. There are clinical trials going on, but they're not mature yet. The studies results are not mature yet. So the technological advances that I wanted to talk about are 3D conformal radiation, intensity modulated radiation, image-guided radiation, which means that we do what is called on-board imaging to make sure that we are treating the area that we want to treat and we are avoiding the surrounding critical tissues. For left-sided breast cancer, there are a variety of techniques. One is called deep inspiratory breath hold. And for any other patient who wants to avoid radiation to the heart or lung, we use prone breath radiation, which is set up on the belly. In addition, we've developed novel ways of delivering partial breast radiation. So this picture here basically shows 3D conformal radiation. When we treat the entire breast in this picture on your right, we use what is called tangential fields. And this is a picture when we are treating the whole breast. And the field basically come from medial, which is the inner side or close to the center, and the lateral, which is close to the armpit or the axilla, are shown in this picture. And our goal is to avoid going through the opposite breast. And the way we do this is directing on your left, you can see this machine is called the linear accelerator, and just directing the radiation onto the person's breast. And inside this head of the machine, we have what is called multi-leaf collimators, which are small leaves of tungsten that are used to shape the field to minimize dose to surrounding tissues, which is shown here to your right in yellow. Field and field is just another technique of radiation where we add extra small radiation fields to the large fields to homogenize the dose distribution or make it uniform, and to literally reduce what is called hotspots or areas that are receiving higher dose, which in turn sort of minimizes the skin side effects. Intensely moderate radiation is nothing but an advanced form of 3D radiation, where the goal is to deliver radiation from different angles, as shown on your right. It basically means that we are modulating the dose intensity around the tumor that enables a more targeted coverage around the tissue that is to be treated, and it decreases high dose to adjacent tissue. So on your right and in the lower right-hand corner, you see there is the IMRT or intensity moderate radiation on the right, and on the left there is 3D conformal radiation. And you can see the yellow area that we're treating here is the area of the dose that we want to deliver to the breast. And this is a CT scan. I should mention that this is like a cut section taken through like a CT scan through the chest. And this is the breast, and the yellow area that is going around the breast is the high dose area. And in this, on the picture on the right side, we are trying to save the heart, and however, it does get some low dose radiation as opposed to 3D conformal treatment. This is another picture, and later on, if you want to see how IMRT looks, on the left, this is IMRT, and on the right is of your screen is a 3D conformal plan. So when we treat regional nodes, we often use 3D conformal radiation. And the intent is to add another field of radiation or another area of radiation that includes lymph nodes in what is called the supraclavicular area, which is a group of lymph nodes above the clavicle or the collarbone, and then also to include the lymph nodes in the axilla or the armpit, which are in going from the infraclavicular area or just below the clavicle here to the lower axilla. And sometimes we treat, I should say a lot of times we try to treat internal mammary nodes where, which I talked about, the medial tangent is widened, or sometimes we have to match another field of radiation with what's called electrons. So if you can see to your right side of the screen with the CT scan here on the right side. This internal mammary field radiation has been added when we treat regional lymph nodes. So the other innovation in radiation oncology is image guidance or IGRT. And so I see that a lot of people refer to their treatment summaries. Nowadays we have this portals called My Chart or My Care, and a lot of you read notes in the visit summary. And when you read your own, like your end of treatment summary note, we mentioned something about positioning, the technique of radiation, and sometimes called image guidance radiation, which basically means that we are taking pictures before or during radiation to precisely target radiation. And there's a technique that is called surface guided radiation. This is a newer technique that is also used for image guidance, especially for left-sided breast cancer. It basically reconstructs, takes an optical view of the patient's body and reconstructs it into a 3D image and helps in better targeting and using deep inspiratory breath hold along with surface guidance. And the goal of image guidance is not only to increase accuracy, to better target the area and reduce the margins that we give for any uncertainty, and it helps to decrease the dose to surrounding healthy tissue. So with the daily imaging, we mostly use X-rays. Sometimes we use cone beam CTs, and in some institutions, people are using MRI scans, but MRI scan for daily imaging during radiation therapy are not that popular. So the other way of doing radiation therapy is with another particle called proton beam radiation. It has advantage over what we call photon beam radiation, but not so much in the breast cancer field, but maybe in pediatric malignancies or childhood malignancies. Currently, there are clinical trials comparing proton and photon, to photon being what we use most commonly. But the initial studies have shown that proton beam causes high dose to the skin and the more cosmetic issues. So it's not that popular. In addition, it's not widely available. A lot of insurance companies do not cover the cost of proton beam radiation, and you have to travel outside of Rochester to get proton beam. So I don't see any advantage of making referrals for proton beam radiation. There may be some role of proton beam radiation in retreatment. And as alluded to before, MRI guided radiation for image guidance is still under investigation. So moving on, let's talk about partial breast radiation, who are candidates and who are the people that we are moving to select for partial breast radiation. So these are the eligibility criteria for partial breast radiation. That is, we are treating just a portion of the breast, not the entire breast. So the tumor has to be small, and the margins around the tumor have to be negative. The patient should have a node negative. Breast cancer is something called lymphovascular invasion. That is, if the cancer goes outside, it's confined to surrounding lymphatics and blood vessels. It's considered a negative marker for recurrence. So we want that there's no lymphovascular invasion. Also for partial breast, in the guidelines for people who are eligible for partial breast, the tumor has to be estrogen positive, a low-grade cancer that is not aggressive looking under the microscope, a single tumor, and preferably a histology called the non-lobular histology, or invasive, preferably called the invasive ductal cancer. And people with germline mutations, BRCA1 and BRCA2 mutations are considered ineligible for partial breast radiation. Also, there are other mutations that we know of. They're different now with the myriad testing where they have started checking 48 different genes. There are other genes that are emerging or the other germline mutations. There are also considered contraindications to partial breast radiation. So partial breast radiation is delivered mostly using external beam radiation. It is more common than using brachytherapy or intraoperative radiation therapy. Basically, the idea is to give a nice margin around the lumpectomy cavity. Like if this is the tumor in green, there is like 100 to 90% dose going around the 2 centimeter, around the tumor bed. And most radiation oncologists used intensity modulated radiation therapy for partial breast radiation. And the most popular regimen this day and age is developed from Italy in a place called Florence, developed by Dr. Levi, where it's done in 5 fractions of 5 treatments every other day to a dose of what is called 30 gray here. Other ways of doing partial breast radiation therapy is with brachytherapy. We used to do it at Rochester General using Mammocide brachytherapy. On the left is a picture showing a balloon that is inserted inside the breast. On the right, there is interstitial brachytherapy. We are using these infrequently in our practice because they're invasive methods, and besides, we have very good results with external beam, and we used to do intraoperative radiation therapy. My colleague used to do intraoperative radiation therapy, that is doing radiation at the time of lumpectomy before closing the sutures. But that fell out of favor because there were more local reoccurrences. So intraoperative radiation therapy in the setting of breast conservation has mostly been dropped out from current guidelines. So for cardiac sparing radiation or sparing lung and sometimes skin tissue, we use 2 techniques. This is mainly for whole breast radiation. These are called deep inspiratory breath hold and prone breast radiation. So let's cover prone breast radiation first. So prone basically means doing the setup on the belly. And what it does, it exploits the use of gravity where the breast falls away from chest wall. It's particularly useful in people who have large or pendulous breasts. It may not be helpful in patients who have a tumor bed that is very close to the chest wall or where we want to treat nodes, or some people cannot tolerate being on their back. So on your right of your screen is a picture where the person is set up supine, and on the left of your screen is prone, that is set up on the belly. And you see that the area of radiation is actually skimming away from the heart and lung when we are using prone breast radiation. Whereas deep inspiratory breath hold is another technique that is used to reduce dose to the heart, mainly for left-sided tumor. So the whole idea is when you take a deep breath in and hold it for about 20 to 30 seconds, what happens internally that the lungs expand and the heart is pushed downwards and it moves away from the breast and the chest wall, and it helps to reduce the dose to the heart. So on the right is a free breathing scan, and you can see on the right that the heart is just juxtaposed or very close to the chest wall, and on the left, it's a deep inspiratory breath hold where it's moved away from the breast or the radiated breast on the left side. So The other innovation that I've witnessed in my career is the fractionation. You know, when I was in training at the University of Rochester, all women who were getting whole breast radiation therapy were coming for 6 weeks of radiation, 5 days a week. But nowadays we are talking about fewer treatments, and there have been many advances in the last 5 to 10 years about doing or de-escalating the number of treatments. So I should have mentioned the unit of radiation is called Gray. That's the new terminology that is being used. It used to be called rad, but now it's called Gray. And just for reference, 1 Gray is 100 centigrade. And when we talk about a fraction, 1 fraction means 1 treatment. So how we've evolved is from conventional fractionation that I was talking about, like 6 weeks of treatment, to what is called moderate hyperfractionation, which means in conventional fractionation, we are doing a low dose per day spread out over many weeks, whereas in moderate fraction, we're giving a slightly higher dose per day, but in a shorter time, that is like, say, 15 to 20 fractions. And the third approach is ultra hypofractionation or extreme hypofractionation, where we're using only 5 to 10 treatments to treat the entire breast. So the ultra hypofractionated radiation, is convenient because the treatment course is delivered in a shorter course. So this, I'm talking about whole breast treatment, and people are able to have, it's less time consuming, and people can get on with their lives, and there's also a sparing of resources. It's attractive for our treatment machines that we finish our treatment soon and get other patients set up for their treatment. So it's sparing of resources from all ends. And if someone wants to go into the history of fractionation, I just put this slide. It's a very busy slide, so I don't want to take away your focus, but it basically gives us the time frame from when conventional radiation was popular in 1990s, and then we started doing more modest hypofractionation or moderate hypofractionation from 2013 onwards. From now in 2020s, we've moved to doing very short, the 5-course regimens of radiation. So the UK fast forward means 5 treatments compressed in a single week, as opposed to the moderate fractionation, which is in 3 weeks. And it was popular from the UK. They call it fast forward because the radiation is done 5 days a week, 1 radiation per day. It demonstrated non-inferiority compared to 3 weeks. And the cosmetic outcomes, the early side effects and the later side effects, and the outcome were the same. And however, there are certain caveats when we are doing this ultra hypofractionated course of radiation. It cannot be done in the setting of mastectomy. We don't have enough data to do it in the setting of mastectomy. When we are doing nodal treatment, we are not using this, although there is a clinical trial going on. It's called the SWIFT-RT trial, where they're utilizing nodal radiation plus breast radiation in 5 treatments and comparing it to just breast radiation in 5 treatments. But we don't have enough data yet to treat it for nodal positive disease. And we don't have enough data for using 5 treatments for a high-risk patient, meaning a younger patient who has triple negative breast cancer or HER2 positive breast cancer. So it's better, more studies are looking at UK, or where UK fast forward is popular is for more estrogen positive or more favorable tumors. And it may not be as good for people who have very large separation between their sternum and their mid-axillary line, or the line from, it's called the line drawn through the middle of the armpit where the breast extends, because it's a high dose and we don't want a very hot, or we want a very homogeneous distribution. So we have to be cautious when we recommend it for people who have bigger breasts. And in addition, the follow-up is short. So whenever I present the option of 1 week of whole breast radiation, I do mention it to the patient that the follow-up is short. So we have to be cautious that way. So we've already covered why do hypofractionation. Has the same outcome as long course. There's reduced cost. There's the convenience of daily travel is more of the shorter course, and we see that the cosmetic outcome, the late and the early side effects are the same. So in terms of doing nodal radiation, we have been using standard fractionation for many years. That is 5 to 6 weeks of radiation. I still use it for my patients who are very young, but for older patients, and for that, I mean, people who are above the age of 50 years, we've seen that we can use moderate hypofractionation or 50 to 20 treatments when we're treating nodes without compromising outcome or increasing the side effects. And we can use this hypofractionation in the setting of mastectomy with or without reconstruction. So I want to mention in recent years that we have also started considering radiation in previously treated breasts, and the standard option after somebody who had lumpectomy and radiation and had a reoccurrence used to be mastectomy, but in suitably selected patients, we can consider retreatment in the same breast. Also, an ideal candidate for breast conservation is a person who has a unifocal or a tumor that's restricted to a single quadrant, but we started considering breast conservation, surgery, and radiation in the presence of multifocal or multicentric breast cancer. So in the field of re-radiation, like I said, the standard used to be mastectomy, but now we can do re-radiation. And the people who are suitable for retreatment are people who have a favorable histology, like an estrogen-positive breast cancer and a smaller tumor. And obviously, we need an MRI before we do that. And some people who cannot have an MRI, they can go through ultrasound and diagnostic mammograms to make sure that the tumor is unifocal. And an ideal candidate for the pre-radiation is a person who the interval from previous radiation to retreatment is 2 years to allow for recovery of normal tissue. And this became more in use after a publication in 2022, where they proposed doing partial breast radiation, that is just treating a portion of the breast in the setting of retreatment and delivering twice daily radiation 6 hours apart in 3 weeks. And in the study, they found that people have conservation of breast, and like 90% of patients could have breast conservation. At other places, we can also do whole breast or whole chest wall radiation, but we have to be very cautious when we are recommending whole chest wall radiation or whole breast radiation. We have to take into account the appearance of breast, how fibrosed or how thick the tissues are, how much dose the surrounding normal tissues have received before we recommend whole whole breast radiation, or for that matter, chest wall radiation or partial breast radiation. So the other indication that we started looking at is radiation in multifocal and multicentric breast cancer. And for your reference, I put in the trial here. So it became popular after the publication of this trial, where the radiation was done in the setting of a multicentric disease, that is one tumor in different quadrants of the breast. And so there were three different lumpectomy cavities that the surgeon operated on, and radiation therapy was offered to each of the lumpectomy cavities with the whole breast radiation. And the outcome was very good. This was published again in 2022, and I have some patients where I've used radiation in multifocal disease. This is a combination of whole breast radiation and boost to different lumpectomy cavities. And also for this, it's better that we get an MRI and make sure that they're not like the tumors not all over the breast, that they're just 2 or 3 at most tumors in different quadrants of the breast. So talking about emission of radiation and breast conservation, especially, who are the candidates? So based on the studies, there is an important study that was published in 2005. It's called the CALGB study. Radiation can be emitted in patients who are older. So we know that older we are, the less aggressive the biology, especially if it is an ER or estrogen-driven tumor, and it's grade 1 and 2, and a tumor that is less than a centimeter, preferably less than a centimeter, that we can emit radiation. We did find, based on this study, that radiation therapy reduced local reoccurrence to 2% versus 9% in patients who did not receive radiation but received endocrine therapy. However, it did not impact survival. There were other studies that came out subsequently. This is called the PRIME2 study, where women were slightly younger, like 65 years of age, with low risk features, who agreed to take hormone therapy. And there's another study in women above the age of 55 years, which have who have low risk tumors, that is, again, estrogen positive, grade 1 or 2, negative margins, small tumors. But mind you, these patients should agree to taking hormone therapy. And that is on itself is, and again, a different topic, where some people are not willing to take 5 years of hormonal therapy because of their side effects of bone pain, fatigue, and risk of bone loss. So when we recommend emission of radiation therapy to patients between the ages of 55 to 70 years, we do tell them that there's not a lot of data for emission, especially for 55 to 70 years. We need more follow-up data, and we also, if we want to impact outcome, patients have to commit to taking 5 years of endocrine therapy. And we are living only longer. We are leading a better life, and we're taking better care of ourselves. So, I tend to offer the shortest possible course of radiation therapy to even my older patients who are not interested in taking hormonal therapy. So we can consider emission of radiation in stage 0 breast cancer, which is called ductal carcinoma in situ, provided it's low risk, meaning it's an older patient, estrogen positive, tumor, widely negative margins, less than a centimeter, and low grade. The studies have shown high grade of local recurrence with emission of radiation after breast conservation. And according to the national consensus guidelines, the emission of radiation is considered a lower level of recommendation as opposed to radiation in the setting of lumpectomy for DCIS. So in this last year, there is this annual Society of Clinical Oncology meeting with publication of an important trial. It's called the Europa trial. It was a phase 3 trial where they considered patients above the age of 70 years who had an estrogen positive and HER2 negative breast cancer that was small in size, and patients were randomized to receiving hormonal therapy alone versus radiation therapy alone. And it was found that radiation therapy did better in terms of quality of life and had the same outcome, if not better outcome. And it was concluded that endocrine therapy significantly reduced quality of life as opposed to radiation therapy. And in this trial, they used partial breast radiation. I agree the follow-up is short, but it is a very good study to look at people who want to avoid endocrine therapy and choose radiation therapy instead. So now what we are doing is that we're looking at biomarkers. There are tests that check what is called the genetic makeup of the tissue. There's a test called an Oncotype. It's mainly done for invasive breast cancer. It gives the chance of recurrence by reading 21 different proteins or genes on the tissue that is stored in the lab. For DCIS, there are two types of tests. One is called the Oncotype, and the other is called the Decision test. We think at this time further validation is required. It just helps in decision making, but it does not replace it for DCIS. And there are studies going around United States looking at omission of radiation therapy. One is in patients who have invasive breast cancer and have an Oncotype score of less than 18, where they're prescribed hormone therapy versus hormone therapy plus radiation. They found there's one study that's ongoing. There's an expert trial that's going. There's a radiation omission study going on in HER2 positive radiation patients who have complete pathological response. So for the 1 to 3 lymph nodes, there is an ongoing study called the MA39 trial, where the tumor is estrogen positive, small tumor, an Oncotype score of less than 25, and they're selected to receive radiation therapy or not if the Oncotype is low. And there's a very new approach. Can we get rid of surgery completely? This is still investigational, but it's worth mentioning here. It's being studied at MD Anderson. So we know that people who have HER2 positive breast cancer or triple negative breast cancer, the tumors are small, and if they have 1 to 3 positive nodes, they have excellent response to neoadjuvant chemotherapy. And they published their results where 30 patients had complete pathological response, and they were not even given radiation, and they were not given surgery. They didn't have surgery, and they had radiation. They're continuing to do well at 2 years. It's called the exceptional responder style, but it's still investigational. So in the neoadjuvant chemotherapy, where the chemotherapy is done prior to surgery, there is a study where if there's a complete pathological response, a complete response in the nodes, we are looking at omission of radiation to the nodes, but again, we need a more mature data. The data is still 5 years. We like at least 10-year data. It's called mature, 10 to 15 years to be called a good study for omission of radiation for nodes that turn negative after a neoadjuvant chemotherapy. So BOOST is giving an additional dose to the lumpectomy cavity in the setting of whole breast radiation. It has been shown consistently to reduce local recurrence, but it is optional in patients who are older, who have vitally negative margins, who have estrogen positive breast cancer. It is consistently shown to be beneficial in younger people. And what we see now that we used to do sequential boost, that is deliver whole breast radiation and then deliver the boost, but now we can deliver it concurrently based on the publication of a recent trial that we can do whole breast and the boost at the same time in 15 treatments, as opposed to doing 15 to 16 whole breast and doing 4 to 5 additional treatments. That's called a sequential boost. So moving on to the side effects and long-term wellness, I think, sorry if we started a little bit late, so I'm just going to utilize that 5 or 10 minutes more to talk about side effects and long-term wellness. I think the focus of my talk was mainly late side effects, but I will touch briefly about the acute side effects of radiation. Um, so the acute side effects means the early side effects occur within a month or within 3 months of radiation or during radiation. So that's called acute side effects, and they range from skin irritation to fatigue to breast discomfort, pain, swelling, and sometimes sore throat when lymph nodes are radiated. These side effects usually improve in about a month's time, but everybody's different, and some people take more time to recover. So fatigue can be a late effect of radiation, so I'd like to talk about it. It's usually mild to moderate. A lot of people continue to work. If they're working outside their home, they continue to work. It varies from person to person. Sometimes it's like taking a small nap during the day or going to bed early. It really persists beyond a few weeks or months after treatment um, is over with, and it's considered to be due to the rationale or reasoning behind the fatigue is body's response to repair the damaged normal cells, and sometimes it's just stress of coming for everyday treatment. In addition, there can be other factors like emotional stress or other stresses in the family that contribute to fatigue of daily radiation treatment. So the way radiation fatigue is managed is making sure you get a good sleep hygiene or good sleep at night. You take naps, but not too many naps. You're well hydrated. You're eating well, and you're getting some natural light. You remain active and do some gentle exercise. And if you have emotional fatigue, it's nice to talk to someone and maybe join a support group or do some relaxation, meet up with friends, um, or talk to your friendly radiation oncology providers and the nurses about it. So the skin side effects can range from a mild sunburn to itching, peeling, occasionally blistering and bumpiness, and most of the side effects resolve within 2 weeks to they started, I should say, in 2 weeks, and sometimes they escalate at the time of treatment completion, but they get better in 2 to 3 weeks after treatment, and then they settle down in the next 2 weeks. So the way we manage side effects, firstly, is prevention of skin side effects. So we recommend patients that wear loose cotton clothes, use a gentle slope like um, Dove and lukewarm water. We are using creams like mometasone. It's like my steroid cream that we prescribe, and the intention is to avoid any inflammatory effects of radiation. It's prescribed or to be used a few hours before radiation and a few hours after radiation. Aquaphor is a good cream that we use for just moisturizing the skin. These days we have no limitation on to use the deodorant or not. When there's desquamation of the skin, we use what is called Silvadene. It's a combination of a soothing material like zinc oxide and sulfur in it. But some people cannot use Silvadene if they have a sulfur allergy. We advise patients that they avoid direct sunlight, wear a higher SPF sunscreen. In our clinic, every clinic is different. We have something called Nebulex. It's a foam dressing that provides a cushion between the skin and the clothes. And there's a soothing dressing called Zero Foam. It's a hydrophilic absorbent dressing that creates moisture environment for the tissues to heal. There's something called Nepitel. Some of my patients have asked about Nepitel. It's a silicone-based, transparent, breathable dressing that is applied to the treatment to reduce skin reactions, like for prevention and post-mastectomy setting especially, but it's not easily available and it's costly and requires a lot of expertise to put it, especially in the post-mastectomy setting, and we don't use it. But maybe it can be used if a wound develops, but it is expensive. So moving on to radiation-induced pain, it can feel like a simple a mild sunburn to a severe sunburn, and everybody is different. Sometimes it can appear as nipple sensitivity. At other times, it can feel like soreness, stiffness, or achiness, and sometimes it's just like sharp shooting pains that come and go, and they start after surgery and take a few weeks to even months to recover. The way the pain is managed is by using cool compresses or cool packs, are usually covered in a tea towel or a washcloth over the skin, or by using anti-inflammatory drugs called ibuprofen or Aleve. But some people have sensitivity to NSAIDs, so we use Tylenol. Rarely we use gabapentin for nerve-like pain. We mix aquaphor and lidocaine for nipple sensitivity, and gentle massage can be used, provided the skin is not too irritated. And sometimes it's time; it just takes time, but eventually things do get better. So the late effects of radiation therapy is something a lot of people, some of my patients who are probably listeners, are very worried about late effects of radiation. There are some patients who are contemplating radiation who have joined this talk, hopefully. But I want to reassure that they are rare in this day and age due to all the modern techniques that we talked about. We do improve radiation planning. We are looking at three-dimensional radiation. We have a better idea of how much the breast tissue can tolerate and how much the surrounding tissues can tolerate. We are doing improved imaging, and we are tailoring radiation to every specific situation, and it's very customized in this day and age. So the more common side effect, late effect of radiation therapy is called radiation fibrosis. It basically means a thickening of the tissues. Whenever there's osis, or it means a late effect. So it means thickening of the tissues, and it's caused by scar tissue, be it the skin of the breast or soft tissues underlying it or the muscle underlying it. And what it causes is changes in appearance of the breast, tightness, and limited range of motion. It can happen 3 months to 2 years after radiation. And like I said before, newer radiation techniques help to minimize it. So when it develops, we encourage patients to wear a well-fitting bra. There are different boutiques. There's one Thelma's boutique that's very popular in Rochester, where you can go and get a very comfortable bra. Exercise is very important when fibrosis develops. So we refer patients for physical therapy and occupational therapy, and they consider doing targeted exercise to chest or the breast, neck, and shoulder, and that helps in improving range of motion and flexibility and just the thickening of the tissue. There's also manual therapy with massage by a certified specialist, deep friction. It can be deep friction or soft tissue massage therapy, and they can be use of pain relievers and muscle relaxant. For breast fibrosis, if it's not responding to PT or conventional measures, sometimes we use a combination of vitamin E and pentoxifylline. And these medications, what they do is they improve the blood supply of the fibrosed breast, and that helps in promoting healing and softening the tissues. It's done for a trial of 6 months. And in very refractory cases, we've made a referral for hyperbaric oxygen, which is high flow oxygen in a chamber. We use it very sparingly, and very rarely different surgical options are used where a plastic surgeon uses a flat graft. Fat is taken from other parts of the body and say the thigh or the abdomen and injected into the radiated skin, and it helps in improving the contour of the breast. So lymphedema is an important topic, and I saw on the Breast Coalition website there's a very good talk on lymphedema management by Melissa Clark. So, people who want to learn more about lymphedema management, I'll encourage you to go to that informative talk. So basically, lymphedema is caused by blockade of flow of lymphatics. It could be in the arm due to nodal radiation, or in the breast because of radiation to the breast caused by the blockade of lymphatics in the breast tissue itself. It can occur early on, like within 2 to 3 months, or it can take years to develop. It has been found that the risk of lymphedema of the arm is lower in patients who have sentinel lymph node biopsy, as opposed to patients who have axillary dissection, where they get 10 to 20 nodes removed and have radiation. So in the treatment of breast cancer, nowadays we have multidisciplinary discussions where we can, who are the patients where we can avoid axillary dissections, especially in 1 to 3 lymph nodes. The standard of care has been to consider doing axillary radiation in place of axillary dissection, because based on different studies, we found that not only did the axillary radiation reduce the lymphedema and the side effects of arm and shoulder mobility as opposed to axillary dissection, but the outcome was the same, especially if the nodes were fewer in number and the tumor size was smaller. And recent trials have included axillary radiation in place of axillary dissection for larger tumors as well, but not very locally advanced breast cancer. The other side is de-escalating surgery, is omitting sentinel lymph node biopsy completely, and but that has to be applied in very suitably selected patients who are older, who have estrogen positive tumors, small tumors that are low grade, and they can be considered for omission of sentinel nodes. And in the last 5 years, there have been studies to support omission of sentinel lymph nodes in people who are above the age of 50 years, but less than 70 years, but that has to be discussed case by case in our multidisciplinary tumor boards that we have once a week. So management of lymphedema starts with taking precautions, that is avoiding cuts, burns, cracks, and dryness in the radiated skin. It's been found that people who are overweight have a higher chance of getting lymphedema in the arms, so having a proper diet and weight management is important. Referral to a physical therapist for a customized sleeve or massage therapy is recommended. Use of pumps, that is pneumatic compression, is used for alleviating lymphedema. Exercise and of the extremity can be done and recommended by the physical therapist, and in very special situations, lymphatic bypass surgery can be considered. So radiation pneumonitis is a rare side effect of radiation. It happens due to the breast sitting right on top of the lung. The chances are rare. It can develop weeks to sometimes months. It can present with dry cough, shortness of breath, and fever. The predisposing factors include smoking, sometimes chemotherapy like taxane-based chemotherapy increases the chances of radiation pneumonitis, sometimes concurrent or the use of tamoxifen at the same time of radiation. Some studies have shown that it causes radiation pneumonitis. It's a diagnosis of exclusion, so Usually the tests that we start with is X-rays, and we look at the area, shows a very sharp demarcation in the radiation field, especially in the upper part of the breast, and there's some whitening and sharp lines around it. CT scan can be used. It has a very good outcome. Most patients respond to steroids. Rarely patients use oxygen or bronchodilators. Radiation-induced heart damage is very concerning to some people, but I want to reassure uh, uh, patients, and not only patients who are considering radiation now or long-term survivors, that it is rare in this modern age. It can happen years after radiation, more prevalent obviously for the left side because the heart is on the left side. But we have discussed techniques that reduce exposure to the heart by using what is called deep inspiratory breath hold or prone, that is laying on your belly, or partial breast radiation. It helps to minimize radiation effects on the heart. We also have a better understanding how much radiation to give to the heart. There's something called mean heart dose that we look at when we decide radiation, and we try to keep it as minimal as possible. Also, it's very important to focus on overall health. That is, people who have multiple cardiac risk factors like high cholesterol, high blood pressure, who are smokers, who are overweight, do not exercise, they've had diabetes and have received a chemotherapy with an agent called anthracycline or anti-HER2 therapy like Herceptin, they are high risk of getting cardiac issues. So we make an early referral to cardiology, and we also have a special cardio-oncology department. So monitoring for heart disease, first we have to be aware of symptoms. What are the symptoms of heart disease? They're the same as the patients who don't receive radiation. One could experience shortness of breath, chest pain, pain while breathing, fainting, dizziness, fatigue. And it's very important to follow up with your healthcare provider and maybe get referral to a cardio-oncology clinic. So people who are at high risk of getting radiation-induced heart disease, the recommendation by the cardio-oncologists that we've seen is getting a baseline echocardiogram if there are multiple risk factors, and then doing echocardiograms every 5 to 10 years, depending on their risk factors, up to 20 years. And there are other specialized tests that can be done. Now, secondary cancers, that is cancer after cancer, are very rare. They take years, at least 5 years to manifest. They occur inside the field of radiation. They're cancers that are totally unrelated to previous breast cancer. And there are certain predisposing factors, like if you're young or there's smoking, you're a current smoker or an smoker in the past, and sometimes there's also a genetic risk, but that predisposes a person to secondary cancer. So the types of cancers that we see are lung cancer. There could be contralateral or cancer in the opposite breast because of any scatter of radiation to the opposite breast. Rarely there are sarcomas. There have been case reports of esophageal cancers, thyroid cancer, blood cancer. They vary in incidence. For older people, I tell them it's like 1 to 2 out of 1,000 people who receive radiation. For younger people, say people less than 40 or 50 years, I quote 2 to 5 out of 1,000 people people treated. And modern techniques show a lower incidence, and getting regular checkups and doing or following a healthy lifestyle is very important when we are monitoring radiation-induced cancer. Radiation-induced nerve damage is very rare. It happens months or years after radiation. It is basically related to a nerve. It's called the brachial plexus, which runs along the neck and goes into the chest. It happens when the lymph nodes are radiated. It can manifest as pain, loss of sensation, or muscle weakness. First, we have to exclude whether it's caused by tumor or not. And it's a very rare side effect. In my career, I've seen maybe 2 cases of brachial plexopathy. and it's managed by using, I'm talking about breast cancer, especially. It's managed by using steroids, sometimes PT or medications. Radiation-induced rib fractures are extremely rare. They can happen early or late. And again, that's because of the breast sitting right on top of the ribs and the chest wall. And they may not, there may not be a history of trauma in the setting of radiation-induced rib fracture. Some people are predisposed to getting fractures. These are people who have osteopenia or osteoporosis. It is detected by X-rays and bone scans or CT, and sometimes we have to use MRIs. They take time to heal. They can be painful, and sometimes hyperbaric oxygen is used for healing. So I think there was a question about radiation for oligometastatic or oligoprogressive breast cancer. So oligometastatic means that when we are treating with radiation, when we are treating with fewer sites that are spread outside the breast, and oligoprogression, basically oligo means few sites that are progressed outside the breast and while on systemic therapy. And basically it means less than 5 areas of spread. What we used is a novel technique. It's called stereotactic body radiotherapy. It aims for doing highly localized radiation targeted to the area of spread. It's done using external beam. It's non-invasive. It is done in 1 to 5 sessions, and it's found to have improved outcome. Radiation for oligometastatic breast cancer has been found to be effective in patients who have fewer sites of breast. So one spread 1 to 2 is better than having 5. So certain areas of metastatic spread respond better to radiation for oligometastatic disease, like bone metastases respond better. Also, if the primary site is controlled and the patient has a more favorable tumor, like an estrogen positive tumor as opposed to triple negative, or the patient has a good life expectancy. So to conclude, and I'm sorry if I've gone above time, that I'd like to say that the techniques of radiation have improved tremendously in the last decade or so. We are de-escalating therapy. We are doing shorter regimens or doing hypofractionation or ultra hypofractionation. And goal of radiation is not only to reduce local recurrence. We are also looking at preservation of quality of life and reduction of long-term toxicity. And every patient is different. We customize radiation suited to every patient's need, their cancer, and the patients must meet appropriate criteria for admission of radiation. So thank you for your time. I'm happy to take questions.
Yay, Dr. Chalo. All right, how about if you do stop share so that we can see your beautiful face a little bigger?
Okay.
And then we'll get through as many questions as we can in 15 minutes. Sound good? And of course, a lot of questions are coming in. All right. There were a few questions about skincare during radiation therapy. First, something that people talk and ask about at the coalition often and bring up are like strong recommendations for turmeric or CBD creams or other things that are advertised as potent anti-inflammatories. And there's curiosity about any like empirical data to support that, or if that's something that you ever recommend to your patients.
So it's a good question. Turmeric is a spice that is comes from ancient India. It's like an anti-inflammatory application that you can put on the skin or take turmeric tablets, but I do not recommend that it be used because during radiation, especially if it's taken orally, It serves as a powerful antioxidant, and for radiation, we need oxygen. I showed you a presentation where oxygen is actually needed for the mechanism of action of radiation. So we wanted to stop. We don't want high dose turmeric to be used orally. In terms of topical application, I would suggest that we do not recommend it because we don't have enough data to support the use of turmeric. Likewise, CBD for topical application. I've not recommended it because we have better time and tested products that we've used, especially mometasone. It's a mild steroid, and multiple clinical trials have been done that have shown that mometasone as a prevention is a very effective regimen. And start with just general skincare, wearing loose clothes and avoid harsh chemicals, and I would discourage CBD. We simply don't have enough data to support.
Okay. There was also a question about would the use of a ZAC inhibitor, which was an autoimmune cream for dermatitis or eczema on the breast, be contraindicated while receiving radiation?
Yeah, that's something I don't know about. I think it would have to go through the dermatologist. I would call the dermatology office and ask what it is. I don't know what it is, if you can tell me what it is, but if it's a steroid-based cream, I suppose we could use it because of the anti-inflammatory effect. But anything else for eczema, I would have to talk to the dermatologist, or you could talk to the dermatologist and touch base with your radiation oncologist to use if it is safe or not.
Okay. Another participant asked if there are late side effects of radiation specifically for double mastectomy patients, because you talked quite a bit about single mastectomy or lumpectomy and breast conservation, but double mastectomy.
So if you're getting a double mastectomy and radiation is needed to both the chest wall, I guess there can be more side effects on both sides. So more chest wall fibrosis, and the radiation therapist would have to come with a very creative plan to target the radiation, to avoid it going to the other side of the lung and the other side of the heart. And we would have to be very creative in the radiation planning. So yes, with radiation coming from both sides, there can be more side effects to the lung, the heart, and the underlying tissues. So it would have to be done very creatively. And I think you should work with the radiation oncologist to show you the radiation plan and what to expect in terms of late side effects. So there could be more fibrosis, maybe more lymphedema, there could be more heart and lung side effects, in addition to rib side effects.
Actually, our webinar next month is about cardio-oncology with Dr. Susan Dent. So I think it's a really good piggyback to this one. There's also a question about the maximum number of weeks post-lumpectomy or post-surgery for when partial radiation can commence, because I know they are often a lag time to allow for healing from surgery prior to starting radiation, and people like to start as late as possible to give themselves enough time to heal. But do you have a recommendation generally?
Sure, it's a good question. So generally speaking, it's the 6 to 8 week period, but every patient's different. So sometimes there can be problems with healing where there's a big hematoma or seroma. So we can extend the time to 12 weeks. And sometimes in very extenuating situations, we wait for 16 weeks, but not beyond 4 months. But usually it's the 6 to 8 weeks, but sometimes 12 weeks, depending on healing.
Okay, that's helpful to know. Are there any particular breathing exercises that you recommend people practice prior to receiving radiation treatments? Like you mentioned that you can protect your heart, especially if it's on the left side, by taking these deep breaths. So are there exercises that you have people practice so that when they're actually there to receive radiation, they've practiced in advance, they're ready to go?
Sure. Yes, we do. Give a small demo and when we talk to patients during the consultation, and our radiation therapists who do the simulation, when they call the patients, they talk briefly about it and they coach patients when they're here. But the exercise that I recommend, it's like doing yoga, like taking a deep breath and holding it for 20 to 30 seconds.
Mhm.
And what happens internally, it's the lung that pushes air inside, that you push air inside and the heart goes down. And then you hold it for 20 to 30 seconds and then exhale. So it's like a deep breathing exercise that normally is recommended for yoga or relaxation, and do it a few times before you go for the actual simulation. And at the time of simulation, they'll coach you again about it. So if you don't get it, the radiation therapists are really, patient and getting you through the whole procedure.
So you said 20 to 30 seconds.
Yes, it is a long time. It's
Yeah,
not a short time, but
yeah,
I
that
guess
definitely requires practice.
it does. It does for sure. It's
Yeah.
doable. I think it's just think about it as a relaxation, for yoga. You're doing something
Okay.
and then taking an exhale.
Scuba diving or I don't know, something like that.
Right.
But it would definitely help to practice. Why or how was the age of 70 selected as the criteria for when radiation can be omitted? And was it a benefit risk algorithm?
Yes, it's a good question. So over the years, that they found that the life expectancy of people was is getting better, and 70 was the cutoff for life expectancy becoming lower. And and we know in addition that older we get, and if we have an estrogen positive tumor, the less aggressive it is. So arbitrarily, they came up with the 70 because we were living 70 and above, but we are living longer. So most of the studies were done for emission of radiation for people who were living 70 and above. So that's how it just came arbitrarily. But nowadays, my 70-year-old patients like golf, they swim, and they're caregivers. So it's a whole the situation of emission of radiation has changed in that setting. So I hope that answers your question.
Are there any studies about risk for rib fracture when DIBH is used? And DIBH was the breathing technique, correct?
Correct.
So many
So
acronyms.
yes, TIBH is the breathing technique. So it's just a technique to reduce dose to the heart. And the lung, unfortunately, does not reduce the dose to the rib because the rib is attached to the heart and moves. Sorry, the rib is attached to the breast. So it moves with the breast, even if you take a deep breath. So unfortunately, you can't avoid the rib when you're doing the deep inspiratory breath.
Oh, that's a good point. All right. And then I think the last question is a big one, but a participant asked, there are some exciting clinical trials going on using biomarkers to omit radiation. And as you noted, Dr. Chawla, the trials go a long time before the data is considered mature. That's something I learned tonight. 10 years, I think you said. Are interim results released or available? For example, the Deborah trial started enrolling in 2021. Do you know of any results to date? It also seems like there is considerable overlap between new studies and studies that are approaching 10 to 15 years, and that there is a reluctance to embrace successful new therapies or procedures before mature data is available. is this your experience? And there's been a lot of gratitude in the chat for you. Lots of
Okay, thank you.
and how excellent you are. So
Oh,
that was a lot of questions in one.
Sure.
Fun with that.
Sure. So the first question is are the results of the DEBRA trial available? So basically, DEBRA trial is looking at people who have less as Oncotype score of less than 18 and randomizing them to endocrine therapy or radiation therapy. And the whole idea being that the low Oncotype tumor would also mean not only lower chance of distant recurrence, but local recurrence. So in that setting, I am not aware of any interim data. It appears very appealing. We do have data from NSABP studies for lymph node positive disease, 1 to 3 lymph nodes where Oncotype and the B51 trial, if you go back, B51 trial was presented last year in 1 to 3 nodes where the Oncotype score was low. In patients who had, I should take that back. So we are currently doing an Oncotype, the MA39 trial is the trial that we are looking at, is looking at the Oncotype test in 1 to 3 nodes and randomizing patients to doing radiation or not doing radiation if the Oncotype is less than 25. And there is retrospective or data from the past that based on which the trial is set up in omitting radiation for lymph node to the nodes if the Oncotype is low. So I hope I got that. The second question.
Yeah.
What was the third remark on that? The overlap.
Yeah, overlap between new studies and studies that are approaching 10 to 15 years, and that there is a reluctance to embrace successful new therapies or procedures before mature data is available. Is this your experience?
It is my experience. And like I said, every patient's unique. So we have to have a multidisciplinary discussion. And you know, you could use the 5-year data to apply to a specific situation, provided you acknowledge that we don't know the results at 10 years. So you might just be interested in looking at 5 years. Say if there's a triple negative patient who had a complete pathological response and in the lymph nodes and an early stage breast cancer who had chemotherapy and they want to avoid radiation, we always present the caveat that this is 5-year data of the study, that you can avoid nodal radiation. But if the patient wants to take that, yes, we make a combined decision making to proceed with omitting radiation in a mastectomy setting. But I think it's just case by case. You know how willing you are, you know how much you can embrace the not the 10-year data and just use the 5-year data.
Yeah. And someone shared that the FDA does require interim reports on clinical trials, but it's not, it may not be publicly available. So we're not sure if safety data is stated in the interim report. And also the FDA has experienced quite a lot of upheaval lately, so not entirely sure on that. But I think we are right at 8:30. So look at that. We did it. I wanted to thank you, Dr. Chawla, for sharing your time and your expertise with us because I learned things. I think everybody else did too. Thanks for answering so many questions. And thanks to all of you who stuck with us and were able to join. Cardio Oncology is our webinar next month with Dr. Susan Dent. And that's on July 23rd, also at 7 o'clock. We'll also be recorded. So hopefully I'll see all of you in a month. And take care.
Thank you very much. Thank you very much, Rachel. And thank you for the listeners for tuning in.
Take care, everybody.